So Dr. A.B. Jacob is from the UK, and he is a clinical consultant there at the University Hospital, Southampton. So he will be speaking to us on medical management versus SLT in a newly diagnosed primary open-angle glaucoma.
Thank you, Kiran. It's always a pleasure to be back home, especially when it's snowing back in England. I'm going to talk to you about the differences between medical management and SLT as a primary treatment for glaucoma. No financial disclosures to sort of talk about. We all know that compliance is always a problem, and various studies have come up with various sort of numbers, but up to 90% of patients can be non-compliant. And in systems where patients have to go for regular renewal of prescriptions, they find that nearly 50% of the patients are not persistent with their treatment, and they're not going back to fill their prescriptions. And we also know about the complications or the side effects of all the drops that we use. I mean, a drop like timolol can sometimes even kill. So you should be aware of it. And with our chronic patients, as time goes on, we are also starting to see changes like prostaglandin-induced orbitopathy, which makes life a misery for both the patient and for the surgeon when we eventually have to get down to operating on these patients. The reasons for non-compliance are very well known. Polypharmacy. There's a little list that I've put there. One of my patients came in with, and imagine an 80-year-old lady who has to manage these sort of lists of medications. I mean, she probably doesn't know whether she's coming or going. So it's not surprising that this is a problem. Studies with regard to SLT have shown over time good responses to selective laser trabeculoplasty, and more importantly, these studies initially showed that they were giving an equivalence of a pressure drop equivalent to a prostaglandin, which is often the first line of treatment in most countries, about 30%. Selective laser trabeculoplasty has a very selective mode of action. It selectively targets the pigmented cells in the trabecular meshwork. So it initiates its activity by getting cellular mediator activity by attracting macrophages to the trabecular meshwork, which will the big advantage of this over ALT is that you didn't have to focus the laser very precisely on a spot. It's a much larger beam that almost covers the trabecular meshwork and a little bit more, and therefore it's very easy to aim and shoot, and it also evenly distributes the laser energy. Because only the pigmented cells are picking up the energy, there is no damage as opposed to the ALT, which causes severe structural damage due to the coagulative effect of the laser. But it does have its problems. There can be an initial intraocular pressure spike, and that is more common in patients who have got very pigmented trabecular meshworks. So pigmentary glaucoma, pseudoexfoliation, these are the ones that you have to look out for. And in these patients, you need to also titrate your energy so that your energy that you're delivering is slightly lower than normal. Most of my patients, when I do the laser, what I tell them is the next day you'll feel that your eye is a bit sore. Take a paracetamol or an ibuprofen, whatever is your sort of poison, and you should be all right. It's very rare when someone complains of light sensitivity or pain and you having to see them after that. Like I did mention, there is an equivalence with regards to the efficacy, and more importantly, you don't have to worry about the side effects other than managing the immediate problems. And you get a reasonably good lowering of the intraocular pressure. And more again, significantly, it is sustained this study from Melamed et al. Is followed up for 18 months, and that showed a good long-term outcome. Therefore, the UK National Institute of Health Research put in about 2 million for a major study. This is called the LIGHT study. It was run by a chap called Gazard at Moorfields. They randomized patients into primary treatment with SLT or drops for either OH, ocular hypertensives, or primary open-angle glaucoma, and they treated aggressively to achieve a target intraocular pressure of about 20% drop in the pressure. And they found that at 3 years, SLT offers fewer drops, less visual field loss, less surgery, and more importantly, in all health economies, less expenditure. Now, the calculations will differ in an Indian setting where the drops are probably a lot more cheaper. But then again, SLT also might be a little more cheaper here. As a result, the UK health people, the NICE, they're called NICE, they changed their recommendation, and they went on to recommend SLT as the primary treatment for open-angle glaucoma and ocular hypertension. And the UK NICE also has a little bit of a fudge in the definition of open-angle glaucoma. They consider pigment dispersion and pseudoexfoliation also as within the same group of open-angle glaucoma. Slowly, everyone has changed. The European Glaucoma Society, NICE, of course, is the UK thing, and the American Academy are also now saying that SLT should be or can be offered as the first line of treatment. We also had a quick look at our patients. In a short audit, we looked at about 100 patients over a period of 2 years. We were not using SLT as a primary treatment. The mix is also quite interesting. You can even find a few patients with primary angle closure as the primary diagnosis and have SLT as a mode of rejuvenating their trabecular meshwork after they've had cataract surgery. Okay, so because it's often a pigmented trabecular meshwork which may have been sort of damaged with the iridotrabecular contact, you can. Most of these patients were on drops, and we found an average drop of about 2.12 millimeters mercury per eye. But the responses varied from patient to patient, and we got some very good responses as well. So, is this practical as a first-line treatment? And that depends on your sort of practice. The thing with SLT is that you need a specialist to deliver this treatment. I mean, we use juniors most of the time, except in one of my clinics where I have to do it myself. And like Thomas George earlier alluded to, I was one of the primary people behind the Vellore Eye Survey, and I have gonioscope patients like, in their sort of thousands. And even now, I find that when I do a gonioscopy and take a patient in for an SLT myself, I find, oh, this angle, it's looking a bit funny. Is it a bit narrow than I thought that it was? So you learn again when you're doing these procedures. But it is a good procedure to do, very rewarding. More importantly, you don't have to use drops on these patients, drops that do have side effects. And we all know that a lot of our patients miss the bus in the early part of their treatment journey. They are irregular, non-compliant early on in the disease. When they start losing vision, they are all very serious about it and all those things. But then by then, it's a little too late. To make life easy, the Israelis have got an option where you can use a automated laser application. Here, the laser is applied directly onto the trabecular meshwork, unlike in the traditional way where it comes from the mirror from the gonioscope. And it's an automated treatment, but you have to have a speculum to keep the eye wide open. but the machine has an eye tracker, and therefore it does 120 spots on its own. So, is it a practical first-line treatment? Again, it depends on your practice, but it is a one-off intervention. It's low risk, it is repeatable, and there's no risk of ocular surface disease. Thank you very much. Thank you for listening.